Hi everybody, welcome and thanks for joining me. This webinar is about the Rural Health Clinic Visiting Nurse Services. My name is Tom Ryan. I'm with Provider Outreach and Education. I'll be your presenter. Today I'm joined by Leanne Foster from my team, who's also a friend of mine. She's going to help with some technical problems, technical support if we need any more, and she's also going to go ahead and ask me questions that are placed in chat. I want to remind you that I will only take questions in chat, so I really do encourage you to take the opportunity to put them in chat. Let's get through a couple of disclaimers here. This information was current when I prepared the presentation. I verified that it was current this morning. Now, again, as of this morning means that Medicare does change frequently. So if something were to change, the CMS current regulations, rules, and information will always override this. Just be aware of that. We will provide responses to questions based on the facts given. We did get some pre-submitted questions and I'll try to answer those as best I can. Some of the information did not be able to give you exact answers with what we have. So we may ask for more information or clarity in chat. We may also have to take some of these back and research some of the issues. We do not have systems access today, which means I can't directly go into a system and look anything up to see how something works. And sometimes with rural health clinics, that's what I need to be able to do. So I may have to take a question back and get back to you in a response. CMS does prohibit the recording of this presentation. They say that you cannot use it for profit-making purposes. We actually ask that you don't record at all. We also ask that you don't take screenshots or any other form of item like that. We will record it. We will make an encore and place it on our YouTube channel. All right, so what are we going to talk about today? Well, first, we're going to look at rural health care clinics and visiting nurse services that they're allowed to do. This information came about from some other questions that we received for rural healthcare clinics, and in particular, whether or not they were allowed to bill for visiting nurse services. So we thought it might be a good thing to talk about that and to talk about the coverage criteria, to talk about the actual services and also billing and payment information. Again, get through what we can, and then I'll answer what I can verbally for questions. If not, I'll take them back. But please remember that the rural healthcare clinic edits I don't have access to. So some of that information I will have to take back and look up. I wanted to make everyone quite aware of that. All right. So again, as you get going here, you have questions, put them in chat, but also remember that I'm going to ask you to take a survey. And again, you'll be given the opportunity to rate me at the end. So that's important to know. When we looked at the questions that you guys had submitted on rural healthcare clinics, in particular visiting nurse services, that's where we designed this for. So I want to give you some basic reminders of Medicare coverage for rural healthcare clinics, because one of the questions was very, very specific to this type of a service. So rural healthcare clinics are responsible for skilled nursing services which are reasonable and necessary for the diagnosis and treatment of the patient's unique conditions. Now, this doesn't mean that they can't do other things. It's just when we're talking about visiting services, okay? Skilled services are based on the complexity of the service, condition of the patient, and accepted nursing and medical practice. So that's what we're looking for as we go through that. Requires the skills of a nurse to provide safe and effective care, which continues to be skilled even if it's taught to the patient's family, or other caregivers. So the service doesn't necessarily end just because the nurse isn't doing it anymore. They could be in a teaching capacity, and it's still going to require some skill, some teaching, some medical skill to do that, okay? Determination is made by the physician based on the condition of the patient when the services were ordered. Key there, physician ordered, and what is reasonably expected to be appropriate treatment for the illness or injury through the certification period. And the other key part of that is, yes, there needs to be an order. We talk about the certification that needs to be there, but also as part of these services, we need to know how long the physician expects this to go on. One of the questions that came in is they got an order for a year. Well, why did it need to be that long? What was the medical necessity, and why were we continuing that for a year? I'm not saying that might not be a valid time frame within an order. I'm saying, hey, let's really justify that. Read through the order, read through what's on there. I don't know that Medicare would ever be like, oh, that's just automatically going to go for the year. Great, phenomenal. So there could be other conditions that would apply to that, and so that it could be valid for a year. So I don't want to say it's not. I just want to say, hey, you better read through that order and make sure that you have it in place and that it explains thoroughly why that length of time is needed during all of that process. The other question that came in and I wanted to answer with that is, does Medicare cover visiting nurse services? And the answer is that's why we're doing this webinar for you. So hopefully as we go through, you'll get all the different components of it and to be able to understand what we're talking about here. So what is the coverage criteria for a visiting nurse service? There's 3 things that must be met. So in order for a rural health clinic to meet this coverage criteria, the first thing that has to be in your area is a home health agency shortage area. This is determined by the Secretary of Health and Human Services. They determine what qualifies as this shortage area. Someone asked in particular if it's a population or a provider ratio shortage and how is it measured? Yes, it is. I don't have an exact measurement. That's not done by us. It's told to us. So what we're looking for is that it indicates that there is a significant shortage in home health services available. Therefore, we're trying to still make sure this patient can get coverage, and that's what a visiting nurse is. One of the other key things is while the patient does have to be homebound, they also cannot be under a home health plan of care because that's done by a home health agency stating that they're going to provide the services. Therefore, the rural care clinic would not be able to provide those services. So even though it may be a shortage area, if there is a home health care agency servicing this patient, you cannot provide home visits. We're going to talk more about homebound in particular on the next slide because that is one of the criteria. Part-time or intermittent nursing care can be furnished by either a registered nurse or an LPN. These hours, while they are actually performing the service, are part of the RHC requirements for nursing hours. So if you don't understand that RHCs are required to have a certain nurse on site or practicing during sets of hours that they're open, it's part of their basic enrollment requirement. Visiting nurse services do count as part of those times. Okay, so it is going to be part of that requirement. I didn't have a lot of questions come in on that. I just thought I would mention it and kind of leave it as a general thought process or a thought bubble there. All right, so those are our basic coverage criteria. Again, Secretary determines there's home health agency shortage. 2, because of the shortage, a home health service is not under a patient is not under an active home health plan of care. And then also they do require the need. There's a medical need for it. And this is what you're going to look for when you're doing the documentation, the assessments, all of that. What is the medical need and what is the order state you should be doing? So what does Medicare define as homebound? I had 3 or 4 questions specific to this. So let's hopefully we get those answered. If not, please put them back in the chat. So they must meet both criteria. Now both are they must meet one of these and they must meet both of these. There's actually more than one criteria. When we say both, we're talking 1 and 2. So they must meet one of the following. Due to illness or injury, the patient must be either under the aid or supportive devices, the use of specialized transportation, or the assistance of another person to leave their residence. If they need one of these, that's one criteria, and they only have to meet one of these 2. The other one would be have a condition such that leaving his or her house is medically contraindicated. You must document which one of these 2 they meet. Why can't they leave the house? And which one of these 2? Now they must also be documented both of these. So one of these, both of these. There must exist a normal inability to leave the home. Why can't they leave the house regularly? Now, this doesn't mean they never leave the house. This may mean that it's very hard to leave the house. This may mean that other things are going on why they won't leave the house. Also, you must document why it's considerable and taxing effort when they do leave the house. So see, they don't normally leave and you happen to leave, this is what that means. It's considerable and taxing. One of the questions came in and said, can you define for us what considerable and taxing effort is? And the answer is we don't have an exact definition of that. It is a case-by-case basis. So you would want to document all of the conditions related to the patient. Now this can be height, weight, malnourishment, dehydration, all of these things that are regularly happening. Perhaps weakness due to medication or other side effects of a medication could be documented to support that it's taxing and why it's taxing. So when you're looking for this in particular, Please make sure that the history is a big part of it. Also, the current evaluation, what's going on with this patient today. What was within the medical record, in other words, the order that showed why you needed it. How are you tying all this back together? I don't have a specific list, which is what they wanted. What would be a specific list of items that will automatically make it considerable and taxing effort? We never are going to have that specific list because Homebound is really based on a patient by patient basis. So hopefully that makes sense. But your documentation does need to support that. When Medicare looks for the definition of homebound, and somebody asked me about this too, we do look in the Medicare Benefit Policy Manual, and here's the chapter and the section to get that from. You select this, it'll automatically open up the website with that for you. You'll be able to grab that right away. Just search for section 30.1. It will get this. If you have more questions on defining homebound, let's get those put into chat and I'll answer those in a little while. The next coverage criteria, and we talked, is an order or a doctor's involvement. So yes, the medical record does have to support that the doctor is involved in the patient's care. This does not mean the doctor is going to the patient's home. That's what's called a visiting nurse service, okay? However, it doesn't mean that the doctor does need to do an order and then determine the medical necessity. They're going to help establish that. So each day you're going to talk about the patient's condition within the general medical note for that day, but the doctor themselves must be involved in establishing the medical necessity. In doing so, they're going to write a plan of care and they're going to write an order for it. Now, does it have to be two actual separate documents, which was one of the questions asked, and the answer is no. It doesn't have to be two separate documents as long as we have both. We're going to order this. This is the plan of care. We want you to go to the patient's home. There's a lack of. This would then also work for a home health order should a home health agency have been available. Okay. So what information are we looking for? One, the doctor must determine the needs based on the patient's condition. Remember we said when they order the service, why do they need it today? What is the need that the doctor sees? That will help you determine what services you should be providing during that home visit. The need must be appropriate for the illness or injury for the certification period. In other words, you can't certify something for a year when it really should only take, on average, or a regular person, a regular healing amount of time, a regular, whatever the situation is for that medical need, 60 days. Okay, so we want to make sure it's appropriate. There does need to be a written plan of care, and that does need to be communicated and kept within the medical record. So the written plan of care. Someone asked if they could get a written plan of care from outside of their rural health clinic, and the answer is yes. So long as you meet the criteria for providing a nursing service, it doesn't have to be the rural health clinic's doctor who ordered the care, right? We know that. So it could be something where they're coming to you even for follow-up after a surgery or something like that, where it could be done in the home. Very rarely, but it could be. And then you have to make sure you still meet all the criteria. That doesn't change. So hopefully that makes a little bit more sense there. We did have a question come in particular about the doctor's involvement and what is expected to be within this written plan of care. So what we're looking for within that plan of care, the types of health services and items that are needed. Also, how often? Is it needed once a week, twice a week, 3 times a week, 7 days a week? What's going on there? Why the home setting is appropriate? Why do we expect this to be maybe a lingering time frame or a short time frame? Also, they need to include some predictable outcomes. What is the goal, objective and measurable? One of the questions that came in was they have a subjective goal in there, according to this person who's reviewing the medical record, and the goal was the patient's goal is to walk to the bathroom. And they're having a discussion on whether this is subjective or objective. From a Medicare standpoint, it's not something we can measure. I don't know how far that bathroom is away. Now, if you said the patient's goal is to be able to move from their living room to their bedroom, which is approximately 100 feet on a regular basis, unassisted, okay, now we have a goal. We know what we're doing. The patient's goal is to be able to effectively administer their medication. Okay, now we have a goal. We're trying to get them to something. What is an effective administration could be the next question, and you want to give a little bit more understanding of that. Making sure they're giving proper dosages, it's done on time, all of those types of things. So there's just a variety of items that would go with this. One of the other things that came up with the bathroom scenario that we had questioned from our medical review team is, what are the obstacles? Are there stairs? So when we looked at this goal, we understood the goal, but we didn't understand how to measure it. We didn't know what you were working with to get there. So for visiting nurses, also include the patient is homebound and that they're unable to go anywhere else. We talked about that with the definition of homebound. That still needs to be within this plan of care. Why are they homebound? What's going on? All of those different types of information, okay? The daily visit note explains the nurse's observations that day, but a doctor must provide the medical necessity for the basis. That is hopefully going to answer the question there where it's what is the daily visit note versus the plan of care. Again, your daily visit is just that one observation care per plan of day or for day, and the plan of care is the overall medical necessity for it. So yes, today we want to know what are they doing up or down. The doctor may consider these daily notes when looking at the plan of care again, because they do have to review it every once in a while. And let me give you an example of one that must be reviewed and why it could be written, but it still has to be reviewed, okay? That is actually going to be our next slide. And it's just important to understand that when we're looking at this, well, it can be written and reviewed at least once every 60 days. So if a doctor writes this for 1 year, does that automatically make it cover that entire time frame? The answer is no. It must then be reviewed again at 60 days, okay? So who can do this? Well, the supervising physician, that makes sense. A nurse practitioner, a PA, a clinical nurse midwife, a clinical psychologist, or a clinical social worker. I want you to note within this list that if the plan of care is not for a service that that person is state qualified for, they would not be able to review that. So someone said, hey, can a clinical social worker review something for medication or for something like that? And the answer is, why within that that clinical social worker is their state license going to allow that? And I can't answer that. It may or may not. Odds are it's not going to, but let's just put it that way. When we look at who's reviewing this plan of care, so we want to make sure that we are getting to someone that can actually do that, but they're also state authorized to write it. Okay. Coverage for visits before the plan of care occurs when authorized in writing by a supervising physician. So what does that mean? A visit can occur when a plan of care is not fully written, but intended. So a physician, let's just use a physician in this, supervising physician in this example, says, hey, we don't have the plan of care fully, but can you see this patient? Here's the basis for it. Here's what we're talking about. This is authorized, okay? And they're going to put that in writing, and then they're going to follow up with the plan of care. Because you know that they want this done and it's going to be based on this plan of care, you still need to know a little bit about what you're doing, right? Maybe it's an initial intake, or maybe there's evaluations that you're going to be doing. That's what you're looking for. So I wanted to make that as clear as possible, and hopefully that answered the question about how things can be paid before a plan of care is actually written. What we're looking for is you still have to have something in writing and explaining why you're seeing the patient. What is the expectation for that? There needs to be some form of judgment given by that ordering person. All right. The next question is in regards again to that time frame question that has a couple of different times, and really regarding that 1 year one. Does the plan of care last for every day? No, the plan of care ends when no visit occurs during a 60-day period. Now keep in mind there's a couple of exceptions with Medicare loves exceptions. So the basics is no 60-day visits, nothing occurred within that time frame, your plan of care will automatically terminate. Now, if that's not true, because the supervising physician recertifies within a 60-day period and indicates that there is a lapse and it was expected or that it occurred because of this, we're probably going to be okay with that. We say probably because it all depends on what they write and then what they indicate. So they're going to recertify it. We just don't really know what they're going to write on there. Also, what if the plan of care has a 60-day lapse on purpose for some reason? So this is a documented intervals are predicted to be for treatments less frequent than 60 days. Well, then of course that would last longer than 60 days. So there's a couple of different exceptions, but it has to be documented in that manner. And we have to be able to understand why it is occurring in that manner. So hopefully that makes sense for how this works. Remember, 60 days is your base goal. If it's going to be longer than 60 days for intermittent, document why it's medically necessary and what makes that 60 days lapse that without being seen okay for a medical standard of treatment or for the patient's medical condition, whatever needs to be there so that we understand, because we don't see the patient. The only thing we have is what you have in writing. Okay. Let's talk a little bit about the services. So what services do we cover? Oops, there we go. They must be medically reasonable and necessary. In other words, the patient must need them for the condition today. So when we really look at the services that are covered, we're really falling back to the Social Security Act under Section 1862A1A, medically reasonable and necessary. This is why we don't necessarily always say it is or it isn't something that's covered. We want to really look back to what's going to meet that. Also, when we look at medically reasonable and necessary, we need to document why this patient's condition is unique to this and needs this service. So what about this patient makes it medically reasonable and necessary for them, and what is unique to this patient's medical condition? Now, it may not be unique overall, like keep that in mind. We're not saying it's unique overall, we're just saying to this patient today, what's going on. Also, we need to document why the skilled services are safe and effective for care. Why is that nurse the only one that can provide that safe and effective care? Sometimes it's training, sometimes it's, okay, we could do this if this was done, sometimes it's a verification. So we want to make sure we're meeting all of those different types of criteria. So hopefully that makes a little bit of sense to people. Please remember, what is the need to continue after teaching is also something that would require. Is there a patient need, the family need? Are there other caregivers? What's going on that makes this medically reasonable and necessary once the training is complete? If you can't answer that, then Medicare will stop paying this service. And answer that means put it in writing in the documentation so that Medicare understands it. So that whoever as a medical reviewer were to pick that up, whether it's WPS or someone else, we will understand why it needed to continue. Oh, I'm not sure. All right, so next slide. Skilled services. It needs to be a skill level of care. I don't know why I'm flipping. There we go. So it needs to be a skilled level of care. So we need to have the service complexity documented. Now, there are certain services you say, oh, Medicare should automatically know it's skilled care. Yes, there are certain things that we can assume or that we can qualify as skilled care. We get that part, but make sure that the patient's condition supports that level of care as well. We talked a little bit about this with medical necessity. What about the patient today means that they needed that specific service and at that level? We also have to make sure it meets the medical, nursing, and medical standards. That's a pretty basic one. In your community, there's certain things that need to be done. Now, we do this a lot of times through process. We do this with asking experts if we need it. Again, we're not reviewing right now rural health clinic nursing services, so this would be an area that we would do this with. But Medicare can use a variety of sources to verify that it does. This could include published research and all of those types of things to make sure it's meeting those good medical standards. One thing that was noted is that you do not get to furnish drugs or biologicals. This is a requirement. This isn't something that we have in particular. Now, it doesn't mean that you couldn't teach someone or have an understanding of how to do that, or you're checking up to make sure they're doing it properly. That's all part of this. It could be any part of that. But you better be able to document why you're doing what you're doing and why it's medically necessary. And, again, go back to those basic things that we talked about when we talked about this for that skilled service. So let's start with some of the basic questions. I put this documentation slide in because there was a few questions regarding just like basic documentation questions. So I thought this is just a really good place to start with that. One, you do have to tell us who the patient is. This must match Medicare. So that means that when you look up the Medicare's patient number, you should be able to find this person. Nicknames are okay as long as we can associate or it's commonly known. So if you said, hey, this person's name is Elizabeth and it says Liz, okay, you would want to clarify that, hey, this is a nickname for them. That's fine. On the other hand, if you said this person is junior, but there's no junior within their name, that's when we start to look at that record and we start to say, wait a minute, what do you know that we don't know? Or how do we know that this is that person without you indicating that to us? Also, the patient's name should be within the Medicare record or as close matching to that as possible. I just explained that. Again, what services provided? This is your daily note, right? What did you do today? I saw the patient, I arrived at their house, I did this, this, and this. It's going to talk about modalities. It's going to talk about any type of service, blood pressure checks, anything you did. Help us understand why you were there and what was it. Basic one, date and time. And I said basic, but it's also one that's commonly missed. So if we don't have that, we don't really know why you're billing what you're billing, and it won't be supported. Again, the documentation must contain a homebound statement with the medical need for that homebound statement, not just that the patient chooses not to leave their house. Well, okay, why are they choosing not to leave their house? What is the medical reason? It does have to contain the address. One of the questions that came in is, does it have to be the patient's address? And the answer is no, it doesn't have to be the patient's home. Let me give you an example. This person was giving an example where a patient is staying with their daughter following a fall, and so they're getting some home visits due to that complication and due to a variety of other things the nurse is needing to go there for. And so is that possible? Sure, that is. It has to have the address, but it doesn't have to be that patient's address, so it doesn't have to match the Medicare file. Hopefully, that makes sense to everybody. If there is a service, how did you do the service? Did you have to transport equipment? What equipment did you have to do? Sometimes it's going to be fairly obvious. Hey, we took an EKG today. Now, I know that's not normally a homebound service, but it could, and it would be a fairly obvious one. I'd have to transport the machine, right? But if there's equipment that isn't necessarily obvious or that isn't necessarily part of it, that blatantly obvious, describe to us how you got it, what you used it for, and why it was there. What's the method you did? Hopefully all of that does make sense. Now, again, keep in mind, if you're like, it's obvious by the CPT and it's obvious because you have to have this to do this, yes, we can make those assumptions. We aren't expecting you to give us all of that type of information. Okay, so that's a little bit about documentation. Again, when people ask, is there anything really specific to homebound and to rural health clinic documentation? The answer is, one, there's no home health service available. That's going to be key in that you fall within that area as set up by the secretary. Now, we can look that up on our end as well, or whoever's requiring the documentation, they'll look that up. Two, that the nursing service is within the scope of that nurse's license. That's pretty simple. They can look that up on the state boards, but that's another thing you want to make sure is documented, and that does fall within their state scope of license. Three, date and time. I can't say that one enough. It is one of the key elements that has caused denials for this when other entities have reviewed it. I don't even know how to express how important that one is to avoid the denial, because we won't even look at medical necessity. We won't go any further without that. Okay, so those are the kinds of things that we really recommend. Again, why are they homebound? They can't leave the house, and why they can't leave the house. And again, the basics that I just went through. All right, let's move on for a moment. And let's talk about billing. Now, remember, someone asked about rural healthcare clinic and billing and payment, and can a rural healthcare clinic bill for services off of a UB04? The answer is you can, but that's not really what we're going to focus on here. In that case, they're billing as something else, and it's going to be a 1500 of some sort, and it's not really considered a rural healthcare clinic nursing visit then. It doesn't meet that criterion. It's not going to be paid as part of that all-inclusive rate. So I'm not really sure what you were asking me on that. I don't want to make it sound like you can't do it. I'm not really sure where to go with that question. So when we focus on the billing aspect, I do want to focus on this portion of the billing aspect, and hopefully that makes sense to everyone. All right. And I just had a screen link. Leanne, can you still PowerPoint?
I can still see your PowerPoint, Tom.
Okay, I saw everybody, my screen literally just blinked at me and didn't come back up. So as long as you guys can see electronic versus paper claims, hopefully it'll pop back up for me, and I'll just kind of keep talking through this as best I can. So These are required to be billed electronically. They are not an automatic exception to paper. Now, there are some times when, yes, they could be. Remember, if your rural health clinic on an overall basis meets the small provider exception, then yes, this could fall to that. And that's 25 or fewer full-time or equivalent employees, but you do have to let us know that. So it's not going to be an automatic thing. So yes, that's when we talk about it. They do have to fall within that HIPAA standard transaction, that 837I. So all of the requirements for that do need to be met. Now, these are basic billing requirements. They're not anything special for rural healthcare in particular. Remember, you still have to have the ordering on there. You still have to be able to identify who that is and have their MPI. That's not really particular to rural health clinics and visiting nurses. Instead, that's just because it's an ordered service. All right. When you do have to default to paper and you do either meet one of those exceptions that we talked about, or having a system issue, which you're telling us, hey, I don't know right now, I can't build this, or I don't bill enough services in general, you can default to paper. We do expect that it is an original UB04 CMS 1450 claim form. That's that red and white, pink and white, whatever you want to call it. But it has to be an original. And we want to make sure that you're meeting with all the requirements for billing that. Now, the paper claim requirements are in Chapter 25 of the Medicare Claims Processing Manual. That was asked very specific, and I think it's because some people don't bill it on a regular basis, so all of a sudden they'll have this one claim that they need to do it for whatever reason, for a system purpose or an exception, and so they need to know where those are at. So that's why I put that on there. If you're wondering, it's to answer the question regarding that we got in. So you can go ahead and take a look at that and walk through that. There is, again, nothing really specific about billing a visiting nurse service for rural healthcare clinic. It's going to follow all your basic rural healthcare clinic billing guidelines. Yes, you have to have a revenue code. Yes, you have to have all of those different things on. So what are we looking for? Oops, I did go through the paper exceptions briefly here. And again, this was asked, is there a time when I can drop from electronic to paper? And the answer is yes. There are system exceptions. In other words, for whatever reason your system says, I can't bill this today. There is a small provider exception. I mentioned that one earlier. Roster billing, Medicare demonstrations, and 2 or more primary payers. So this would be an example where the patient has another health insurance through an employer-based plan, but maybe he was in a car accident. So your visiting nurse service today is related to that. It's 2 primary payers. Some people's systems can't do this, and so we recognize this as an exception. These exceptions are listed again in the Medicare Claims Processing Manual, and you're going to want to look at Chapter 24 and then read through this sections here and the subsections to get through all of the information. So hopefully that answers that question. Again, if you need more on that, let me know. All right, this is the more specific stuff you need. What type of bill do you need? I need a 01X, and again, X just representing that space holder. I need revenue code 52X. That represents what we're looking for in terms of rural healthcare clinic and visiting nurse. Without that, we can't process this. You do have to have your line item data service, and you do have to tell us with G0490 that this is a visiting nurse service. We also do expect that you will append modifier GC. This information is actually set forth in the Internet Only manuals again, or those Medicare Claims Processing Manual, Chapter 9, Section 50. Without this information, we cannot process your claim. It will return to provider. And what it's looking for is to fix whatever you're missing here before we can do anything with it. So if you have some of these codes and not other ones, especially this G0492, or you don't have this modifier, or not 492, I'm G0490, without a modifier or a variety of other pieces that just don't seem to fit together, we'll suddenly have to stop it and say, fix this first. Okay, I want to let you know that we'll look at this information. This is paid as part of the AIR, the all-inclusive rate. It is not a separate payment. It's not something you're going to get additional money for. So it's part of that bundle all-inclusive rate you're going to get. Now, remember, when you're establishing an AIR, this is established based on the previous cost report that you filed, which goes through all the services. So if you don't have a valid cost report filed, you will not get paid at all. And it's not just about the visiting nurse services, you just won't get paid, and you've got to get that updated first. So you want to make sure you keep your cost reports timely and filed correctly, but that's a whole nother class and could be at least a whole nother hour. We do different classes on those. Check those out from our audit department and make sure you're aware of that. Okay. But I wanted to especially make sure that you are aware that this isn't an additional payment. This will be part of your all-inclusive rate that you do receive under the rural healthcare clinic. All right, so in conclusion, what do we want to know? First, we just want to know that one, in terms of rural healthcare clinic, yes, you can do visiting nurse services, but we want to make sure we meet those criteria and key criteria that we really do need to make sure are met. One, that you're in that area of shortage. And that area of shortage does need to be determined by the Secretary of Health and Human Services. It's not for any other type of shortage area. Without that, we won't be able to meet this. Two, you need to make sure that you document why the patient is homebound, why they cannot leave the home. Three, the plan of care needs to document that as well and also needs to be valid. Remember, if it's written for a longer period of time, again, the example was 1 year, we need to know why it's not being written with a 60-day increments, or is it written for that and it's just reviewed every 60 days, or does it cover a longer period of gap for 60 days? So it's going to be every 90 days, and here's why that's medically necessary and medically reasonable. So again, lots of different ors on that one, but make sure the plan of care is there and the documentation then supports that. Make sure that your daily notes support this as well, and your daily notes are what occurred on that visit each day. Without those daily notes, we will not be able to pay you. So it's important to make sure you have all of that information together. That brings me to the end of the conclusion. So I want to give you a resource here. And these are some different things you might want to take a look at. I do like the Medicare Benefit Policy Manual. This is your visiting nurse services. This is your basic starting point when you're looking at it. Let's just take a quick look at that. And so what we're going to do is we're going to go to the Medicare Benefit Policy Manual. We're going to go to Chapter 13 and Section 190. Let's go ahead and jump over to the website. And we're going to go ahead and go to cms.gov. Oops, or we're going to type it correctly first. Let me start there. There we go. Once the CMS website opens, you're going to select Medicare. Now remember I said this is the Medicare Policy Manual, so you're going to go to the regulations and guidance. And the reason that I'm bringing you this way is because we had a couple of people that thought this would be in coverage, and it's not. It's actually in the manual system. And so we're going to go to regulations and guidance, and then we're going to slide over to manuals. Inside the manuals, you do need to go to the internet-only manuals. And once you're inside the internet-only manuals, again, you're going to look down and you're going to find the Medicare Benefit Policy Manual, also known as Publication 100-02. Once you're inside this, then you just scroll down. Okay, keep scrolling. And we are looking for the chapter that we wanted, and I forgot the chapter. Let me look real quick. Chapter 9, sorry. Chapter 13, so rural healthcare clinic and federally qualified healthcare centers. And then once we hit that, this is where the visiting nurse services information will be. Okay, so we just read through everything. Staffing requirements, this is what we talked about for RHC, where we talked about the nursing requirement, where it has to be within a certain time and how much staffing the nursing has to be able to provide, things like that. RHQ services down here. Keep going down. We will hit different sections. We will read through the different areas. I forgot the section again. 190. I knew it was down a ways. I just couldn't remember exactly how far down. There we go. So there's your visiting nurse services. This is what we went through. Okay. We went through everything on here, but I want you to know where it's at. We did have some questions in particular about that, and this is what you're going to do. If you select any of these, you down, it'll just start walking you through the information you need. Okay. Keep in mind that when you're inside here, it will reference other manuals that may have additional information for you. It will also reference things like the Social Security Act or the Code of Federal Regulations. It'll help you get through what you need to know, all of these different things. Here is the reference for the 60 days that someone was looking for, that reference in particular, and why it needs to be done every 60 days. And this is what we're talking about here. This is 190.5 within that area. I think that was the only question regarding that. Okay, the Medicare Claims Processing Manual, Chapter 9, this just gives more information on how we process a claim. So again, it's going to be the same basic setup, except you're going to go to a different area, and that would be Chapter 9. Let's jump back here for 1 second. Medicare Claims Processing Manual is 100-04. And you can look at Chapter 9, and again, it just talks about how we process all rural healthcare clinic claims. So this is your basic and starting point. And then you need to move further to be able to make sure you have everything you need on there for the visiting nurse service that we talked about. And then there's a booklet from CMS. It's called Information for Rural Health Clinic. I'm going to go ahead and give you a little cheat. What I did here is just link this booklet. You can go out and navigate on the CMS website like I did earlier and just navigate to this. It is in the Medicare Learning Network files, but you can also just use the link that I gave you. It's way easier that way. This is what I prefer. Just some great information as you're getting started and you're looking for it. It'll get you some of those basic, like here's your basic visit information, here's your basic payments, if there are things that are outside of your area. So this is more than just about visiting nurse services, but I do think it's an awesome resource that you guys may want to have and have available to you. All right. That brings us to question and answers. I will tell you that I did go through the pre-submitted questions as I went through. Hopefully I didn't miss any, and if I did, please feel free to ask them. Otherwise, go ahead and put those in the chat and we'll see if we have any questions available now.
Tom, we do not have any questions in the chat.
All right, well, you guys are gonna let me off easy today, and maybe that's because I got started late, I don't know. But a couple of things to keep in mind. I want to give you a couple more reminders. This is going to give you an opportunity to put questions in the chat if you still have them. We do have a National Provider Enrollment Conference coming up. With rural healthcare clinics, they are unique in that these they enroll differently than some other types of clinics would. So we know that they have to complete certain portions of an application, and it's a little different. So if you're interested in learning more about that, please take a moment to consider attending this. This is an in-person conference, and it is in San Diego, so that may be another incentive for why you want to go. But the times do vary and the topics do vary. So take a look and see if that meets your needs or if you're interested in that at all. If you cannot attend an in-person one, not related to provider enrollment, but just general provider compliance, is a national conference held by CMS. This is a virtual conference. So this might be another opportunity for you to meet with CMS and kind of hear what the MACs have to say and CMS is saying about provider compliance. It's going to give you a variety of different educational topics, plus some compliance and professionals will be there. Plus some compliance professionals will be there. So we want to make sure that you're aware of it. Again, if you're interested, take a look at the agenda, take a look at the registration, consider attending that one as well. Did a lot of talking there, Leanne. Did I get any questions?
We do not have any questions in the chat, Tom.
Okay, everybody, that brings me to the end. I want to thank you for attending and remind you to take that survey. Give me whatever feedback you have. I'd really like to have the opportunity to hear from you and to be able to help you better. Always remember to include topics not related or not specific just to rural health clinic. So if you wanted something like Medicare secondary payer, or you wanted something like eligibility checks and how to use the portal, we can do any of those types of things, but please include that on this as well so we're well aware of what you're looking for. Take the time to review our live events page and our encore page. That's the live events. Will have upcoming education. The encore will have this video plus others posted that may be applicable to what you're looking for additional information. So on behalf of Leanne and myself, all of Provider Outreach and Education, thanks for attending and thanks for participating today. We do look forward to your survey comments, and we hope that you'll join us in the future for more education. Thanks, everybody. You may now disconnect.